So a very good evening to everyone. I welcome all the panelists once again for this session. So this panel discussion is on the topic local flaps for oral cancer defects. So as we all know that oral cancers form the commonest cancer in India. Their resection leads to complex defects and significant changes in functional and aesthetic outcomes affect the quality of life of these patients. So the simplest method of reconstruction that achieves the highest level of function should be chosen. So if we see the history of flaps, it dates back to 1000 to 800 BC, that too from India by Shushruta, where he has described the nasolabial flap in his book Samahita. The first scientifically documented human cadaver and as well as the dissection of the flaps was performed in Greece long time back, again 250 BC. Again, then during Roman times, there was description of random circulation pedicle flaps. It was William Harvey who described the concept of arterial inflow and venous outflow. As we all know that it was Aryan in 1979 who revolutionized the head and neck reconstruction with the use of pectoralis major myocutaneous flap. This was soon followed by the introduction of free flap transfer, which has actually made the reconstructions aesthetically better and even functionally better. So as we know that free flaps are the most popular and versatile flaps for reconstruction of oral cavity defects. They can reconstruct small, medium, large defects. They can even reconstruct complex, challenging three-dimensional defects, and they are oncologically safe. Better donor morbidity as well as simultaneous rehabilitation can be achieved. So, but however, this panel, we will be only discussing the use of local flaps, and the discussion is for soft tissue defects and reconstruction. So moving ahead, I would just would like to discuss this point, Dr. Sajid, your point that on what factors your reconstructive decision making will depend.
Yes, good evening all. The main factor is the defect, the size of the defect. So if, as you said, if it is only the soft tissue defect, we need only a soft tissue to be replaced. And if the size of the defect is not too large, most of the time a local flap would suffice. We don't need to overemphasize on a free flap in these kind of settings of small and medium-sized flaps. And of course, financial part also. Financial and the resource factors also plays into according when we are making the decision.
So by saying the bony defect we are not including, I would just like to clarify that I have not included the segmental defects, but we will be including where the marginal defects are there along with the soft tissue, because just for explanation. Yes, please go ahead, Doctor.
So that is what. So mainly based on the defect, for small, medium defect, we will consider flaps, and especially if it is not a salvage, if it is a de novo case, that a local flap will be possible. But if it is a revision surgery or a post-radiation surgery, a local flap cannot be considered in those settings.
Correct. So Dr. Shan, would you like to add something?
Yeah, Poonam. One thing I would add to add is the site of the defect also makes a difference to me in my practice, because if it's a floor of mouth reconstruction, I would see like whether to include irrespective of other factors, whether we should include a free flap or whether we should use a local flap. An issue with like a site like floor of mouth or the undersurface of tongue, the issue what we find is if we use a fasciocutaneous flap, whether it be free flap or any other fasciocutaneous flap, the tongue gets tethered down and the mobility of the tongue gets affected badly. So we have been facing this issue, and this has come down really, it has improved after using mucosaline flap for floor of mouth or undersurface of tongue reconstruction. So that's something which I would consider, because a floor of mouth or undersurface of tongue, I would think a local flap like a islanded facial superior to a facial flap. But when it comes to a actual defect, it may not make a difference, and you may in certain cases you may switch, like you may consider free flap to be superior also. but for a floor of mouth, undersurface of tongue. And another site which I would say is like a palatal defect. A limited palatal defect, you can use a free flap as well, but islanded facial artery, I mean, it's like when you move it like a propeller type flap, in a propeller like way, you don't need to island it. You can just mobilize it towards the palate and cover it in a very simple and easy way, and you will have a like for like appearance in the palatal area. So these two areas, I would prefer a local flap to a faciocutaneous flap. But on the other sides, the size of the defect is large. A faciocutaneous flap would be better in many situations. In some situations, it may be equivalent to a local flap. And one more issue which I would consider is the situation, the patient condition, whether the patient has comorbidities, whether the patient is high risk for surgery, and whether the patient is a post-radiation, post-surgery, like post-surgery, post-radiation recurrent patient. All these may affect my treatment decision making.
Correct. Thank you. So there are several factors which influence the reconstructive decision making. Few of them we already discussed, like the patient factors. This includes the patient lifestyle and expectations naturally, the medical conditions, the major cardiac morbidity or the renal morbidity, where long surgery may not be feasible. Then donor site scar and morbidity, that where is the location of the donor site. The hospital factors like universal healthcare systems, where there are long waiting lists, the availability of intensive care unit, if it is available or not, microsurgical instruments, paramedical facilities for appropriate rehabilitation, and obviously the surgeon factors. So, Dr. Swagnik, what criteria do you use to classify the defects? Like we just heard that the size of the defect is one of the criteria. So, how do you decide like, oh, this is the kind of defect and I will be doing this kind of local flap for this?
Local flaps are ideal for small oral cancer defects, early cancers with no nodal metastasis and with no segmental mandibulectomy defect, no bony defects. So T1, T2 cancers, buccal mucosa or tongue or even the palate can be well reconstructed with a local flap. But one thing I would like to stress here is that especially for buccal defects, preferably it is always preferred to put in a vascularized epithelial flaps vis-a-vis split thickness skin grafting, which causes significant trismus in the post-operative period.
What are your thoughts, Dr. Manish?
Hi.
Hi.
So I think in terms of classification, there are certain classification given by few centers like Kochi, and there's also an Italian classification for tongue. And obviously you're showing the maxillary defect classification, which is given by Liverpool by James Brown, which is quite famous. It does tell you about the different types of flaps to be used for maxillary defect, but mainly they talk about the free flap reconstruction in maxillary defect in Liverpool. But I think with the Kochi one, I think class 1 defect, class 2 defect can be considered either by primary closure or keeping it raw or a local flap, while class 3, class 4 would benefit more with a faciocutaneous free flap.
Correct. So I think there are a lot of classification systems. This is the previous one by the Amrita group, which already Dr. Manish has described. Then there's another classification by Liu et al. And then they have included several kind of like vertical and the horizontal defects. But again, this is a bit cumbersome and difficult to remember. But in fact, they have included different kind of defects together. And then there is a simple classification, which I felt was much more easier and appropriate in most of our cases, which is the Square et al., where they have described the defects as small when the defect size is up to 4 centimeter maximum diameter. Medium, they called it if the size of the defect maximum diameter is up to 7 centimeter, and large if more than 7 centimeter. So various defect characteristics we already discussed, like the size of the defect, the subsite involvement, the different tissues involved, either whether the mucosa is involved, skin is involved, bone is involved, is going to affect the type of reconstruction. Then the functional dynamics, like we saw, if it is involving the floor of mouth, it is involving the tongue, or it is involving the buccal mucosa, is going to make difference, which we'll be discussing further. Then prosthetic rehabilitation is, if possible, for the defect is also important point to be considered. So,
Poonam,
yeah.
before we go further, we have to give the message that when we mean local flap, these are the flaps which are taken in and around the neck as well. So many times the message is given that local flaps means whatever is taken from the oral cavity itself. So here we are talking about those flaps which are taken from the neck as well. Okay, correct.
Correct. So, so Dr. Devendra Gupta, do you reconstruct every defect? So, does every defect need reconstruction? So, what is your take on that?
So, you already described that the various defect size, classification based on the size as well as the site. Hello, am I audible?
Yes, we can hear you, Dr. Devendra.
Yeah, so the small defects, especially in the tongue, we can get away without doing a reconstruction. But if it is a buccal mucosa, then as Dr. Swagnik already told that we should use an epithelialized, vascularized epithelial flap. So the size and the site would be the main criteria. We can get away without doing a reconstruction in maybe small tongue defects, T1 lesions.
Correct. So the aim of reconstruction is to restore oral competence. We know adequate mouth opening, mobility of tongue should be restored, speech and swelling to be restored to the maximum extent, and the separation of oral cavity from nose, nasal sinus, and the neck. So whatever kind of reconstruction if it can achieve, we can go ahead and do that. So there is a newer concept right now is that of reconstruction elevator. Earlier we used to read about the reconstruction ladder, but now they have converted it into elevator, where the concept is that the most important, the most appropriate flap needs to be selected, whether it is the least complex type, which is we see the arrow which is going down, where it is a primary closure, or it is healing by contracture, or it is a negative pressure therapy, or it is a skin graft. Whereas the upper arrow shows more complex kind of reconstructions like regional flap, local flap, and free flaps. So whatever flap is appropriate for a defect which can reconstruct and can provide the aims of reconstruction can be used for the same. So, like we just saw that the small defects, which are usually less than 4 centimeter, if we take it for ease of understanding, they usually can be managed with the help of primary closure, but then it should be a tension-free closure. Then secondary intention healing is also one of the options, but one need to be careful that with all these options, there is always a chance of decreased mouth opening, and that needs to be taken into consideration. Then skin grafting is one of the options which we all have used, and naturally local flaps, which we are going to discuss it further. So like Dr. Sajid already described, what are local flaps? Local flaps are situated in proximity to the resected area. They provide the same type of tissue. The color and texture matching is similar, and they do not require specific microsurgical instruments, but they have naturally a lot of limitations. They have limited arc of rotation, limited availability of tissues, and they do not provide bulk. Moreover, presence of nodal disease may interfere in some cases. So I have put few of the local flaps here. This list is not exhaustive, and I have included most of them which we use at our institute. So some of them include the buccal pad of fat we all have been using for years, tongue flap, palatal flap, nasolabial, malolabial flap, both pedicle islanded, fan flap, submental flap, supraclavicular, and platysma myocutaneous flaps. So again, Dr. Sean, what kind of defects? I think this we have already discussed. The defect that you already said, small defects, medium-sized defects, most of the time they can be reconstructed with local flaps. Floor of mouth defects, like you rightly said, along with the tongue can be reconstructed with. Usually the large defects are not suitable to be covered with the local flaps. So here we'll not be discussing exclusive lip or cutaneous defects. So for defect A and defect B, Dr. Sean, what local flap will you be using? So one, defect A includes only the palatal defect, while the defect B includes the part of alveolus also.
See, in this defect A, if we can mobilize the the palatal flap and close it, that will be better. Like you don't have to disturb the buccal mucosa at all. For the second defect, you have a larger defect, and it's with the loss of tooth as well. So in the second defect, I would consider using a facial artery myomucosal flap. And while suturing, I'll just make sure that the tension at the palatal flap to the FAM interface is tension free. Like you can distribute the tension in such a way that a little away from the center towards the periphery, there can be a little bit of tension, but at the center, you don't have much tension because the sutures may give way. So that would be my consideration.
I think some of the defects which we have used, in our reconstructive measures is palatal flap, buccal pad of fat. I think we all use, but usually that will not reach that area for this thing. I think I have written that nasolabial or milolabial flap, submental flaps we have used, and the tongue flap we have used for the reconstruction. We'll come to each and every case where it is good or not. That will be discussing. Yes, Dr. Sajid, you would like to add something?
As Sean said, the first one, if possible, palatal rotation flap is a good option. Otherwise, radial forum fares well in these kind of defects usually, because even when we rotate the palatal flap, the edge seems to be a problem. Sometimes a small defect in this, because if you are taking the, I hope this is a bone defect. There is a bone defect as well in this kind of.
Yes, we have included the bone defect as well.
So even a small defect which is remaining will cause a trouble to the patient. So we have to be careful in these kind of scenarios. The second patient, if it is a female, my choice would be a submental flap. Tongue flap, etc., is little cumbersome to manage because we have to put the tongue to the palate, and then it is little difficult to manage. Nasolabial, in small defect, more lateralized. If it is not more towards the midline, this can be used. Another one is the temporalis muscle flap, which can be used again in these kind of scenarios.
Correct. Dr. Manish, you want to say something?
Yeah, so I think local flap is important, obviously, in this case, but I need to emphasize the point that obturator can be a very good option in this situation. It will really help in early rehabilitation, easy for postoperative monitoring of the disease. Palatal flap, I still feel, will be difficult in the first defect as well, after getting all the margins and rotating the mucosa. But yeah, obturator, I think, would be my first choice actually in these cases.
Correct. So I think we all agree to that most of these defects, I think a larger flap, palatal flap can be option, Dr. Sean said, but again, for the second defect, obviously it is not, and we need a bit larger volume of the flap to cover the defect. So this is the kind of buccal mucosa defect, defect A, defect B, where defect A is mainly the buccal mucosa defect, and defect B is the defect for which involve the marginal mandibulectomy.
You are
and
not audible, ma'am.
Hello? Hello?
Yeah, we can hear you. We can hear you.
Sorry.
Yeah, now you are audible.
Yeah, so the defect A is mainly the buccal mucosa defect, and defect B is the defect where there is marginal also will go along with the upper.
You are not audible, ma'am.
Am I not audible?
Yes, now you are audible. So
Yes, yes, Swagnik, you can go ahead and tell me.
Yeah.
How will you reconstruct if we have local flaps only?
Yeah, for this patient, this is a buccal mucosal defect. Now, going through a list of flaps for local reconstruction, if it's a buccal, it's a pure buccal mucosal defect. Hello?
Yes, we can hear you. We can hear you.
And if a submental flap reconstruction is a good option for this patient. Again, as I emphasize, I will avoid putting in a skin graft. Other options being a tongue flap, or even maybe a palatal rotation flap based on the greater palatine artery. but preferably we are talking of local flaps. I would prefer for a submental flap, but I'll be very careful selecting the patient, as these diseases have a high chance of nodal metastasis to level 1B and 1A.
Correct. So I agree with Dr. Swag. Yes,
Before
please
that,
go ahead.
in all cases where we plan a local flap, we should have a plan A as well as a plan B. Because only when you go in, most of the time you realize that the defect is much larger than you have expected. Sometimes you, if you send frozen, your margin may be closed and you may have to excise a little more. And there are situations in which you might see in a better light settings, you will see a little bit of leukoplakia or premalignant lesions in the surrounding mucosa. So your resection may go a little wider. So always have plan A as well as plan B. Like if it is in the first case, I think a buccal fat pad would be a good option. But sometimes as you go in, if it is a little larger, it will not cover with buccal fat pad. Always you should get consent for the nasolabial flap as well, because nasolabial will fit in very nicely in this patient. Second defect, yes, submental flap is a good option if it is a female patient, or if it is a male patient, my choice would be a supraclavicular flap.
Correct. So now these are some of the flaps I have described, which we have used, or I took it from the literature also. In a way, I agree with Dr. Swagnik that usually we also don't use submental flap for the buccal mucosa defects, because the chances of nodal metastasis to level 1B is a bit higher, and we usually prefer it for verrucous. But then that can be a point which can be discussed further also. So, so these are the floor of mouth defects. Again, this
can I have a point? One important point in the previous case is that these when you resect such a lesion, your base is formed by the buccinator muscle, and if you see the anatomy, the facial artery mostly will be resected in the resection. So the defect will only leave behind skin and subcutaneous fat. So using a nasolabial flap for this case will be, I think, for pure buccal lesions, a nasolabial flap is not a great option.
Correct. Dr. Manish?
Yeah, I would just, on Swagnik's point, I would suggest that a reverse nasolabial flap would work in this scenario. They work really well with good mobilization and primary closure in that area.
Correct. So even a reverse flap can be used for that situation. But I think that's a point which can be debated further, which Dr. Swagnik also said. So I think again the floor of mouth defects, the defect A is unilateral, B is involving a bit more larger, and C is involving whole of the floor of mouth. Okay. So Dr. Sean, your point, how will you reconstruct?
In any of these patients, in all three patients, if the patient does not have any trismus, I would consider an islanded facial artery myomucosal flap, because I've tried other flaps. I've started doing with the faciocutaneous free flap. But the issue is the tongue movement gets affected badly. With the islanded facial artery myomucosal flap, I found that there is a definite functional advantage. That's why I was trying to share that video with you so that people would understand. So in this particular situation, islanded flap would be my choice if the patient does not have any trismus. In any of these.
Dr. Devendra, your inputs?
I agree with Dr. Sean. However, we can use an islanded nasolabial flap also in such situation.
Dr. Swagnik?
Yeah, Dr. Sean is a master of this FAM flap, and Devendra is a master of islanded nasolabial. So I will go with both of them.
Will anyone of you consider infrared flap?
Yes,
Dr. Sajid?
Yes. Infrared flap is a very good option, especially in the third condition, that is C, because the defect, it is not only in 2 dimensions, the third dimension also, it will be a large defect, because it seems to be a probably an infiltrating kind of lesions wherein we will have a defect like this. In those kind of situations where we need a bulky tissue to cover the floor of the area, the infrared flap fares very well. So in C type of defect, and also in B, we can infrared will fit in very nicely. Submental flap, if it is N0, of course, we can consider that in a female patient. And my point against Sean's islanded fam flap is that whenever we island it, both in islanded fam as well as in nasolabial flap, the marginal mandibular nerve gets damaged. That is only the worry which I have, because I have also used it initially, but that is a problem. That has been a problem always, and so that to avoid that, the other flaps would be a better choice.
So we have also in our practice used all these 3 flaps for reconstruction, and naturally each one has its own limitation and advantages. I think we'll be coming again for that. So these are the tongue defects. Again, tongue defect A and B and C. So what is your take? Anyone can take this thing. How will you reconstruct these? Do you think there is a possibility for local flap for reconstructing these kind of tongue defects? Anyone of you?
Yeah, Poonam, can I?
Yes, Dr. Shah.
If it's an anterior tongue, tip of tongue defect, anterior 1/3, if we do not reconstruct, the tongue gets an unusual appearance. And another thing is like certain voice, certain sounds can get affected, like the post-dental sounds and all get affected. So in the anterior 1/3 defect, where the free unattached portion is affected, so I would prefer to do a tongue advancement so that the unattached tongue portion remains in a working condition, and the defect is somewhat transferred posteriorly. So I would like for an anterior 1/3 defect, that would be my choice. For a larger defect, like which is involving the anterior portion of the tongue, I'd be very concerned, because any of the flaps, if we put in the front portion of the tongue, the issue would be the tongue mobility gets affected. So if it's not affecting the floor of mouth, if it's just the anterior 1/3, anterior 2/3 of the tongue, the whole of it, if it's going, if you consider putting in any flap in that position, the tongue mobility actually can get affected. That's what I felt, because the free movement of the tongue, the native tongue mobility can be affected because of the flap bulk. So for the lateral defect, like the A defect, so for this any faciocutaneous flap should do very well. So that's what I would think. Like, I would like to get the other opinion.
Yeah, Dr. Swagne.
Ma'am, for the first defect A, if a local flap is to be done, I would prefer a islanded nasolabial flap. The reason being so, for islanded nasolabial flap, we don't need to have a classical N0 neck. Even it can be done an N+ neck as well. Second thing is that the advantage of islanding is that we are having a large arc of rotation, and it behaves almost like a free flap while attaching to the tongue. So the restriction of the tongue mobility is not there in our islanded for vis-a-vis if we use the random pattern flap or any other local flap. Second and third defects, I would opt for a macrovascular reconstruction.
You will opt for a free flap?
Free flap, yeah.
Okay.
Not.
Anything else, Dr. Sajid, Dr. Devin, Dr. Manish, you would like to add?
If we have decided on doing a local flap, all these 3 defects can be covered with a local flap. We have various options like the nasolabial flap. It has to be islanded if you are using it for the tongue. Both in I think first 2 A and B, we can use a nasolabial flap, whereas B and C, it would be better to use an infrared flap because it would give a good bulk. Always we have to be we have to plan our flap and also have the backup if it is not reaching well, because the infrared flap, sometimes we may get stuck by the reach of the flap.
Correct. So in our experience also, hello, yes, anybody would like to add? So in our experience also, we have our own data, which like in the type A and type B, we have been able to reconstruct majority of our defects with the help of islanded malolabial flaps. But the defect C is difficult, and it would be preferable if we could reconstruct it with a some other flap, preferably a free flap. So we know that tongue defects, they can be closed primarily, but none of this defect was ideal. Local flaps, again, for tub defects we discussed, can be islanded melolabial flap, then FAM flap, infrahead flap, and submental flap. These are some of the options. I will not be going into details. This is the study by McConnell. We know that the defect size up to less than 1/3 or 30% can be closed primarily. But there are data where they have which has shown that even tongue which is kept raw or covered with skin graft gives better mobility or swallowing. So there are contradictory. This data, few patients, 104 patients which we collected prospectively, and we have seen majority of our defects which were type A, type B, and we were able to reconstruct them with islanded melolabial, FAM flap or infrahead flap. And FOM, again, we discussed with the similar buccal mucosa, marginal or upper alveolectomy defects, we use supraclavicular or platysma myocutaneous flaps. Buccal mucosa lip defects, we have used submental flaps. In our data, we saw that melolabial was the most robust flap. We did not see out of 63 a single loss of flap in these patients, because naturally if the facial artery is there, vein is intact, it is a very robust flap. However, there were few donor site morbidities. Then again, the supraclavicular flap, we had a lot of failures, not complete failures, most of them were partial failures, and there were donor site morbidities also. So this is just our experience, not many cases, but this is few of the cases we did at our institute, which we collected prospectively. So again, this is, we know, just for once again we are discussing. So buccal pad of fat, would you use it regularly, or like Dr. Sajid, what's your take on it? We'll just remaining 10 minutes.
Any small defect, especially for T1 and T2 buccal mucosa, buccal fat pad is a first choice, because it is very readily available. You don't need to disrupt any other area, and it heals beautifully within a week's time. But the one point for caution is that there may be a trismus. So if the patient is already having submucous fibrosis on the other side, better do not use this flap, because this buccal fat pad also will cause some amount of trismus. And second, thin patient with a hollow cheek, you may not get much of buccal fat pad. Again, you may have to plan another flap like the nasolabial. Sometimes these kind of buccal mucosa defects, though nasolabial is a very good option, sometimes what happens, the depth margin may not be adequate, and you may have to go in or do a deeper resection, and the facial artery will come along with it, and your nasolabial will not be possible in such situations. So always plan another flap in these kind of scenarios.
So buccal pad of fat usually for very small defects up to 4 centimeter, which the literature suggests in our experience also. And most of the time there should be no OSMF, and mouth restriction, the restricted mouth opening, like Dr. Sajid suggested, has to be taken care of. Then palatal flap, again, Dr. Stone, your point for palatal flaps, when will you do?
Yeah, palatal flap, small palatal defects, even if it is involving the bone, palatal bone, we can reconstruct with the palatal flap, or a larger palatal defect, including the bone, including the palatal bone, you can reconstruct with the facial artery myomucosal flap, which is completely islanded but not taken down to the neck. When it is moved like in a propeller-like fashion, it can easily cover most of the palatal defects in a very simple and easy way. So that's why I was telling, initially I was using radial artery forearm flap for these defects, but after switching to FAM for palatal defects, I felt that it is simpler, easier, and gives some mucosal appearance to these defects.
So palatal defects, flaps, again, they are ideal for small defects on the palate, maxilla, or retromolar trigone, and they can be used for these situations. Tongue flap, anybody who has experience with the tongue flap, who does tongue flap? Dr. Devendra, Dr. Manish?
I have used it for other situations like the alveolar defects or the gingival defects, because the tongue, it usually sits, the transfer is very easy, it sits. And very occasionally for the lip reconstruction. These are all difficult to place, and for especially for the posterior defects. If it is anterior, that pull always creates a trouble.
Correct. Dr. Devin?
So, well, for tongue flap, I do not have much experience, but rather than taking a posteriorly based tongue flap, what I do is I do a hyoglossus release and then surface the buccal mucosa with the undersurface of the tongue, which comes over the undersurface of tongue, especially for the small posterior defect of the buccal mucosa retromolar trigon.
Okay. Dr. Manish, what is your suggestion?
I agree. Yeah, sorry. I agree with Dr. Devendra. If the buccal mucosa defect is significant, hyoglossus release would definitely benefit. The only thing I think tongue flap might be useful is in some small palatal defect or RMT defect, where you can switch it. I can switch the mucosa in that region. But obviously, it comes with the morbidity of the procedure, as well as it's a two-stage procedure where it needs division. So we have to take into that while planning.
Yes, I agree, because tongue flap has its own morbidity, especially a tongue which is a mobile and functional organ. And usually we also prefer it to be used as the last resort. So we'll be using other kind of local flaps before using a tongue flap. So infrahead flap, once again, anybody would like to comment on this? So in our practice, it is a wonderful flap. We usually use it for the floor of mouth defects and for tongue defects also, but we have seen that usually the limitation is the reach of the flap, because it depends upon the location of the superior thyroid pedicle. And usually the failure rates are not very high. Superficial skin loss we had encountered in 1 or 2 cases. However, it is not a very difficult flap also to learn, but a level 3 note is a contraindication. So Dr. Sajid, any point you would like to add?
Yeah, 2 points. Sometimes we may end up with this venous congestion of the flap because of the pull and traction. But many a times these are all superficial. The skin sometimes gets peeled off, whereas the muscle, the robust muscle stays, and then that heals secondarily. That heals without any issue. So many of the time, if you see, there will not be total flap loss, only a partial loss that usually happens. Second point is that in some of the situations, after you raise the whole thing, only you may come to know that there is a reach issue because of the vein, because the reach is mainly because of the vein which is draining it. So in those conditions, what we can do is we can cut the vein and anastomose it to the facial vein and then surpass the problem. Like
Better you do a radial
single anastomosis to the vein.
Then it becomes a pre-flap.
Becomes a free local flap.
Pre-infrared flap.
Pre-infrared flap. Pre and local both. So then this is one of the flap, which is platysma myocutaneous flap. We have experience of 4 or 5 cases only, but we felt it is a good flap. In fact, this usually is ideal for a small to medium-sized defect, buccal mucosa defect. We can cover the buccal mucosa, marginal mandibulectomy and upper alveolectomy type of defects with the help of this. But again, the venous blood supply is unreliable, and usually you can sometimes have the venous congestion of the skin flap, and the skin loss can be there. This patient, in fact, I had the skin loss, which I have shown here, but the neck morbidity is not there at all, and it closes in the same transverse neck crease of the neck dissection. Any experience anyone would like to add to that? Anyone?
Not used it.
Yeah, it's a very limited experience. Oh, sorry.
Yes,
sternum-mastoid flap. Again, it looks initially looked like a sternum-mastoid flap, but the sternum-mastoid flap also has the same scenario, but again, not a reliable one.
Yes. So I think there is another submental flap. I think we all have done it, and it is a very good and robust flap in our series also, in our experience also. The failure rates are minimal if you trace the submental vessel properly. However, nodal metastasis to the oral cavity from the oral cavity is a question. And in our institute, usually we prefer to do it for the verrucous lesions, or like where we don't have a positive biopsy. Maximum we have to do well differentiated SCCs, but we don't prefer it to do for the moderately differentiated cases. Anybody would like to comment upon the submental flap, the advantages and the limitations?
That's an excellent flap, submental flap. We have used quite a number of situations. 2-3 important points to be preferably avoided in males because of a beard issue, if possible. Second point is that the flap, the patient selection is important with very thin built patients with minimal subcutaneous fat. Again, the flap is an issue. Otherwise, a very robust flap and reliable. Again, we can take into consideration buccal mucus, as ma'am rightly said. We only consider it for verrucous lesions of the oral cavity where there are chances of neck nodal metastasis are minimal, and to be preferably avoided in a tongue cancer patient where the flap just lies below the mylohyoid separates the tongue from the flap. So yes, verrucous lesions, small defects, female patients, good flap.
Yeah, I completely.
Can you show the previous slide?
Yeah, sure.
See here, the flap has been drawn as or taken as a horizontal flap. Okay, in these kind of scenarios, the nodal dissection will be a little issue. But if you are using it for a smaller defect, we can take the flap as a vertical flap, that is from the mental area to the hyoid, and then the thickness, the width would be around 2 to 3 centimeter, especially for those smaller or a medium-sized defect of the tongue. So in those scenarios, the flap lies directly over the digastric muscle, and you can do level 1A dissection on the lateral side, and also complete the do the complete level 1B dissection medial to the flap. Sorry, the other way, the lateral to the flap and the medial to the flap level 1A. So that way we can do a neck dissection. So in those conditions, it is completely oncologically safe. There we do the neck dissection in a proper way only.
So you mean to say that the flap is based basically on the anterior belly of the digastric?
Basically on the anterior belly of digastric. So onto one side of that, we can even complete the
do
level
the 1A clearance also.
Yeah.
Great.
Correct. So I think the only one point I would like to add is that usually when we do at our institute the submental flap, we include the anterior belly of digastric along with the part of mylohyoid muscle, and because the vessel is usually sandwiched between the two. So that is the area where the dissection is difficult because the vessel becomes very thin. And the other point is that if you have to be meticulous and dissect the vessel there between the anterior belly and the mylohyoid muscle, and there can be nodes also. So their area you have to be particularly careful when you are dissecting that area. So that's the point I would like to make. So we have already discussed submental flap is easy to harvest, pliable. Large flap can be raised from one angle of mandible to the another, or it can be made smaller also as per the need. We prefer it for verrucous lesions, and we have used for different defects. Tongue carcinoma, we are not very sure, because like Dr. Swadnik said, if it is, we have to remove mylohyoid as a margin, then this will not be appropriate. So this is another flap, which is the supraclavicular flap. Again, it is a good flap. However, again, our experience with supraclavicular flap was not that great. We had a lot of morbidity, especially the partial losses of the flap, but it is a good flap if we can reconstruct it. If it survives, the venous blood supply is an issue. So anybody would like to share their experience with this? Because we are only left with 2-3 more minutes and we'll be rushing it to them.
An excellent flap for buccal carcinoma, wherein T2 or T3 buccal carcinoma, wherein you remove the entire buccal mucosa from commissure to the RMT, and from upper GB sulcus to lower GB sulcus, or even along with the bite resection. In those kind of defects, as it is, I think this case which you have shown is a bite resection. This flap is a very good option. It is, the final result is almost similar to the radial forearm that you would place. The reach should be checked prior to the surgery, because some patients may have long neck and a short shoulder. In those patients, it will be a little difficult. In other ways, it's an excellent flap for those conditions.
Yes, thank you.
The deepithelialization has to be done very, very carefully, because deepithelialization should not damage the subcutaneous blood supply. That's the reason. And while inserting the flap, the distal edge, the bleeding of the distal edge needs to be checked very clearly, and there should be pretty good arterial bleeding from the distal edge. Otherwise, the distal edge is prone to necrosis.
Yes, I completely agree.
Another point is that the person who is doing the flap should do level 4 and level 5 dissection. He should not The resident should not be doing the neck dissection and the consultant comes later or to do their flap. That will create a trouble.
Yeah, because by that time the vessel will be gone. So we did a few cases of even bipedal supraclav flap, and in fact they survived. So I just put the photograph that it can be used for them also sometimes, but again it is a bit unpredictable, at least in my experience. There can be shoulder morbidity sometimes if the defect size is more than 7 centimeter. You have to,
important.
yeah, so there you can put a skin graft. Otherwise, it can be closed primarily. So width of the flap is also important to be taken into consideration. Then islanded facial artery myomucosal flap. I think this better photographs. This were shared by Sean with me, and this have been used by for heart pellet. And the other one is a nice video, which is. So we can see this FAM flap has been used here. So wonderful tongue mobility. It has healed very well. Yes, Dr. Sean, would you like to add something?
No, I think I've already told about this.
Yeah.
So this is the reason why I prefer islanded fan for floor of mouth, because it definitely has a functional advantage. So that's just the point. I mean, I just wanted to show this video just so that people understand, because I found it difficult to get that mobility with any faciocutaneous free flap or any faciocutaneous flap. So that's why I wanted to show that.
Yeah, sure. So I think the last and I think the most commonly used by, at least by us, islanded malolabral flap. Swagnik, your word on this?
Yeah, ma'am. We have been doing it for, I mean, previously quite a lot of cases, and me and Devendra published it in Laryngoscope. So this is a good flap. The points here is that the first thing, it's to be avoided in pure buccal mucosal defects. The width of the flap is important, because you take a too wide flap, then it causes a very bad functional and cosmetic outcome. So width should be preferably between 2.5 to 3 centimeter, not more than 3 centimeter. And the flap is a large arc of rotation.
flap discuss कर रहा है.
It's a large arc of rotation and can be used for the reconstruction of the opposite side also.
Yes. So I think islanded, we are already ahead of our time. So just to this thing, the take-home message, the appropriate choice of deconstruction depends upon the defect and patient characteristics. Local flaps can be used in certain situations as discussed. Learning curve for local flap is not very steep. Well versed with vascular anatomy of the face and neck is very important. And assessment of defect and meticulous planning is important for planning of the flap. Primarily, closure of the donor site is preferable, and donor site morbidity should be minimal. And zero status of neck is preferable, and oncological safety is foremost in selection of these flaps. With this, I thank you all because we are already ahead of our time. And I thank you, everyone, Dr. Sajid, Dr. Sean, Dr. Swagnik, Dr. Devendra, and Dr. Manish for their contribution to this panel and telling us the various options and the limitations of these flaps. Thank you so much.
Thank you, ma'am.
Thank you, ma'am.
Thank you.
Thank you.
Thank you.